It's there. I don't doubt it. The money's in the system. We just have to do the work to increase the value, reduce the waste, and support those frontline people like we would do. Look, making a widget's fine, but making healthcare, that's personal, right? That's something you could consume, I could consume tomorrow, or someone we love. You want that to be the best.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
Today on Power Supply, we will speak with Kevin Capatch, Director of Process Engineering, Enterprise Supply Chain Services at Geisinger. We're going to be talking about GS1 standards and UDI today. We're also going to talk about Kevin's unique role in process engineering within the healthcare supply chain, how he found his way there, and the benefits of engineering healthcare, but it needs some foundational work, Gary. And we heard all about how to build that foundation, or how we're trying to build it underneath the house, I guess is the best way I'd say it, with GS1 standards. So excited to talk to Kevin today.
Absolutely, Justin. I've heard some great things from you and your meetings with him at the ARM convention, which I think was absolutely successful. But understanding how that engineering lean process comes into state and connecting clinical to supply chain, we need it. It's definitely a need there, and understanding current process to future opportunities and involving where he's coming from and his expertise. Can't wait to hear what he has to share with not only you and I, but Hayes too. Hayes can learn some things, so we're happy to have him on the show.
Well, welcome back, Gary. We've missed you over the last 3 seasons. Stay with us, everybody. We'll be back after a short break with Kevin.
I'm Hayes Walder.
This is Gary Skinner.
And I'm Justin Poulin.
From the studios of Healthcare HQ, you're listening to Power Supply.
We are speaking now with Kevin Capatch, Director of Process Engineering, Enterprise Supply Chain Services at Geisinger. And Kevin, I had a chance to meet you at the ARM conference, so we're super excited to have you on the show today, especially because you know a whole lot about GS1 standards and UDI. We've had a couple of podcasts here and there over the years about UDI but not so much the GS1 standards and kind of the background. So I'm really excited to have you on the show. Thanks for coming on.
Yeah, thanks for having me. Hopefully it'll be enjoyable for the audience as well.
Absolutely.
Well, what the audience doesn't know is we're already all giving each other a hard time. So I think this will be fun for the audience. And Hayes is always telling us, like, let's keep this fun and light and let's have fun with it, because supply chain can be sometimes a little bit of a dry topic. But we've got a great following of listeners that, stay with us. And I think, mostly it's because Hayes picks on Gary.
Okay, bring it. Sounds good.
Well, by the time Gary showed up, you know what I'm saying, Justin?
Yeah, I mean, seriously, Gary, like, now that you're back, I think we have to address this on air a little bit. Like, we've missed you, but if you haven't been listening to the shows you haven't been on, you've been taking a little bit of a beating in your absence.
I'll take it. Wanted and welcome. Let's roll. You have a hard stop, Justin, as usual, so let's roll.
Wait, who has a hard stop?
All right, Kevin, welcome to the show. Let's get a little bit about your background, because I know one of the things is that, prior to healthcare, you were outside the industry. And so I love hearing about how things work in other industries. What are the lessons learned? And especially about people's experiences when they come over to healthcare. So maybe just tell everybody a little bit about your background and then how you found your way to Geisinger.
Yeah, I think that's a good opening story because it sets a foundation for probably what we're going to discuss about GS1. I'm an electrical engineer by degree from the Penn State University. I've used standards in my practice in manufacturing for 25 years before I brought my skill set over to the healthcare world. And it was interesting to join healthcare that late in the stage of development. But as we know in this country, a lot of manufacturing went offshore, right? So you have to try to find a place to keep your family fed and protected. And Geisinger was in my backyard, right? Unfortunately, manufacturing wasn't. So Geisinger kind of answered that need. But I think I told you, Justin, I have a disease from working in manufacturing. It's called lean, and you see waste everywhere. And nobody prepared me for what I was going to see when I walked into healthcare and just saw people that were, challenged to do some of the greatest work I've ever seen. But really, from a process support standpoint, there was kind of a void, and that's why trying to get involved in anything that puts a foundation under our clinicians, I'm all in, right? I'm all in.
Hey, Kevin, jump in there a little bit. Do tell a story or two if you got one. Like you came over, you're in healthcare, maybe the first 2 months, you're walking around, and like, what was that like? What did you see? Your good, bad, or like, oh my goodness?
It's interesting you asked that because I told my boss at the time, Deb Templeton, she was the vice president of supply chain. I said, Deb, this doesn't work. In the real world of manufacturing where it's competitive, you can't walk into the manufacturing plant in the morning and see the frontline workers running around at 20% of their time looking for things, trying to find things that are charged or that work. And we backed that up with a study very shortly after I joined healthcare supply chain. And unfortunately, that pie chart proved out, right? A frontline nurse spends almost 20% of their day doing logistics activities. Unfortunately, we also discovered they spend about 25% of their time doing documentation. And you would say, okay, yeah, they have to update the HR, right? That's a normal function of a nurse. But never in my practice of manufacturing did it take more time to get the stuff you needed to go to work with and document what you did than to actually do the value or the service. So that's shocking, right? And I said to her, I don't think you could run a manufacturing plant for a day with those conditions. So when we talk about lowering, the cost of healthcare and increasing the value, I think it's just rich with opportunity. I think once we figure out how to do that, we're going to be really impressed with how well our people can perform when we take the hurdles out of their path.
Was anybody shocked or surprised when you presented that study, those findings? I'm sure. And did you put dollar amounts to it? In other words, RN makes X dollars an hour. She's wasting X dollars. I'd be curious.
Yeah, we did. We actually did an ARC study, an ARC grant. And the interesting conclusion of where that started is it came down to a conversation where we had to go from a pilot to full on, right? We were going to try to roll it out. And at the time, we made an interesting proposal that we would take any open nursing position, because you always have open nursing positions, right? And instead of rehiring nurses, we would rehire what we were testing, which was called a care support associate, somebody that would actually stand in that gap. Now, we're not talking a nursing assistant. That's pretty popular. We're not talking the LPN. That's been used. This is purely somebody that's going to connect the back supply areas. And there's many, right? When you think about any health system, it's not just supply chain, right? It's linen services, it's food services, it's mail. There's a lot of things that move on the highway. It was actually what we called 19 silos, and they had 39 different delivery systems, because even linen had clean and dirty linen, clean and dirty scrubs, right? So when you peeled the layer off of that and looked at all of that going on, we dropped it where it was convenient for us, but not where it was convenient for the nurse. We called it the worst rickshaw business in the world. So we were in the process of trying to close that gap. And the care support associate would have been typically about the same pay rate as somebody we'd bring into logistics, right, or food services. But they would have been permanently on the floors. They would have been working as part of the team to close that gap. I don't want to say that we're done, because that was just a start. But that's, to me, like the last mile of healthcare that really needs engineering.
And I'm assuming your nurses loved it too.
Oh, the nurses were on the pilot with us. Unfortunately, we had 2 floors that were our pilot floors and 2 that were our control floors, and the control floors weren't very happy.
Valid study.
That's
Valid
a great
study, Kevin.
Yeah.
So Kevin, just for clarity on my standpoint, so what was this new position and part of this study? Was it a connector between supply chain and clinical, or was it? Okay.
Yeah, so it was a connector between all those logistics operations, right? That person would have taken the linen and put it either in the room if the nursing assistant even needed to do a bed change, right? So when we talk about clinical support, to us, a nursing assistant is support of a nurse, right? So if the patient needs their dirty bed changed, then that's something we need to make sure happens effectively and efficiently, right? Just like getting a med administration done. To us, no differentiator, right? Care is care.
I love this study. Yes.
So I think it would be interesting too. I mean, I think you kind of highlighted it a little bit, but can you go a little bit deeper into your role of process engineering in supply chain? Because I honestly, I don't hear that role very much. And so, like, how did that even come about? Was it a position they actually had open, or did you find your way in and bring this to the table, so to speak?
Yeah, I think you bring your skill set with you no matter where you go, right? And some of it you use day one, and some of it you go, man, I can't wait to use that. And I think process engineering was I'm going to have to wait a little bit to use that. There's a very popular term in healthcare, and it was called re-engineering healthcare. At my first GS1 standards conference that I attended and actually spoke at, I actually opened up the presentation with a question, Justin, instead of closing with anybody have any questions. And I did it for a reason. I really felt that I needed to grab people's attention. So I said to a team of people attending that session, I think I can prove that healthcare is not broken. And you could correlate that to saying not engineered. And the reason that I thought I could prove that, I could ask a question, right? When was this fixed? And I dramatically paused, and just waited to see if anybody would answer. And to this recording date, nobody has answered that question. And I think the reason they haven't answered it, we haven't engineered the healthcare support. There's tons of biomedical engineering. We have amazing clinical engineers that make sure our MRI machines and our CT scanners and our ultrasounds and every piece of electronic equipment is calibrated and ready to be used. But that's not process engineering. Process engineering is what I did in the factory to make sure when the worker came into work, the worker made value happen. And when you have the lean tool set, you get really, really good at taking waste out of a lot of processes. So it'll come. I don't doubt that at some point in time when we get serious about healthcare and we really want to lower the operational cost, it's there. I don't doubt it. The money's in the system. We just have to do the work to increase the value, reduce the waste, and support those frontline people like we would do. Look, making a widget's fine, but making healthcare, that's personal, right? That's something you could consume, I could consume tomorrow, or someone we love. You want that to be the best.
100%.
1,000%. Yeah.
100%. Let's kind of go to you were talking about GS1, and getting involved in GS1. How did you get involved in all of that? Like, were you pulled in or did you seek it out?
I had a great boss. I mentioned her name already, but she threw me in head first. And one of the things that I scribbled down on my whiteboard when she was telling me about the role and what I was going to have to get involved with, and this is weird, but I actually looked at the board when I had to move out of my office, and I wrote G1S. So I actually could do a presentation someday and say I couldn't even spell GS1,
Correct.
right?
Yeah.
But I said, Deb, what do you need me to get involved with? She said, well, nobody's covering the pharmacy side of things. So this is 2009. I get a phone number and an email from a gentleman named Bob Celeste at GS1. And Bob invites me to a call to talk about drug supply chain security. Might be one of the scariest calls I've ever been on. It's 2009 and you're talking about drug supply chain security and you're going, I don't want to know that it's not secure, right? I want to think that it is secure. But I remember listening for about 45 minutes and I said to Bob, I came off mute and I said, Bob, this is Kevin Capatch from Geisinger. and you could have heard a pin drop. Like, there were very few providers on the call. It was mostly manufacturers, wholesale distributors, right? And I said, I'm sorry, but there's a lot of acronyms in healthcare, but I have to ask a question so I can sort this conversation out. I said, are you talking doc, D-O-C-K, that you got to get the drug to, or doc, D-O-C, that you got to get the drug to? And the answer was, Kevin, I think we're talking D-O-C-K. And I said, well, we've got a lot of operational steps to make sure we get it to the patient. And I
100%.
put my phone back on mute, and I thought, you know what? This is going to be an interesting thing to be part of. Now, if you know anything about the drug supply chain in 2009, they were talking about California and Florida pedigree. And I said on one of the calls a little bit later, as I got a little bolder, I said, you guys do realize that if you only make 2 states have the highest pedigree, then the other 48 states get questionable pedigree. I said, this needs to be a national policy, which eventually became, right? That was technically my first entry point. It was 2011 when they asked me to come speak at a UConnect conference. There was no healthcare track in 2011 with GS1. Healthcare was trying to get into data standards, but we didn't have an official part of GS1.
So I'm going to backtrack a little bit to a quote that you gave me when we were first talking. You said, healthcare supply chain can't be broken because it's never been fixed. What do you mean by that?
Boy.
Yeah. So if you'd have caught me prior to healthcare and said, Kevin, the widget maker on line 4 is broken, right? I would go out, I would get the manual out, I would go run through the checklist, I'd get the machine back online, right? So something that's broken has a previous state, a fix. And when you look at healthcare delivery, support delivery today, I can't find evidence that we wanted it this way. I think we let it evolve to this level, but I don't think this is by design. I don't think this is engineered based on my definition of engineering, right? I again, if you go back to the beginning part of the conversation, I couldn't run a factory this way. I need my people working. I need them working to the top of their skill set, the top of their license. They can't be running around. They can't be wasting time looking for information. They need to be doing what we pay them to do, which is create value. And when it comes to healthcare, that create value means people get well. That means they get home to their loved ones sooner, right? They have faster recovery times. We all know that there's a negative side to healthcare, right? I mean, sometimes people pass away, but there's even a responsibility there to make sure they're cared for while they're in that phase of the care pathway. So they need time. They need time to be with the patients, not running around looking for things.
I love it. That's so good.
So, Kevin, I mean, this kind of brings us back to GS1. I mean, if it wasn't designed this way, then clearly there's probably some foundational pieces that should have been put in place in the beginning. But because of, like what you said, the way healthcare has evolved, they weren't there. And now, you know, to catch up with other industries, we've got to find a way to put those foundational pieces back in. I know we're going to focus on GS1 and that's, you know, and UDI, and that's a foundational piece, or we wouldn't be going with the conversation in this direction. But do you see any other foundational pieces that are missing before we dive into GS1?
Yeah, I mean, there was a fundamental foundational piece missing in healthcare, and standards help in this area. But, you know, somebody asked me one time if I had one word to choose that I would want to bring to healthcare, it's visibility. I've spent probably the majority of the time in the last 18 years I've been in healthcare bringing visibility to inventory or equipment that is charged and ready for use. It's amazing, right? 2010, I was asked to evaluate an inventory control process for one of our procedural areas, non-OR, but a procedural area. I said, you know what? I'm going to do the lean thing, right? I'm going to go to the Gemba. I'm going to go talk to the people that do the work. Met a very nice, you know, technician. And I said, can you show me your inventory process? And he picked up a tablet and a pencil. He walked me into a room and opened it up. And it looked like, you know, maybe the back room of any type of a supply closet, lots of boxes with numbers and barcodes on them. And I said, so how much do you have? And he said, what do you mean? I said, how much dollar value is sitting in this room? He said, oh, gosh, I don't know if I know that, right? Maybe once a year we try to count it. But he said, I literally don't know unless I would stop and count everything. Turns out in 2010, when we implemented a point of use, point of care system, he was sitting on $1.5 million of inventory. And unfortunately, some of it was expired. This is 2009, right? Retail is so far ahead of healthcare when it comes to these types of techniques. And we're not talking important things in retail, right? These are life-saving devices. These are things that will stop people from dying or make them better. That's just been a mission to bring that visibility across anything that we need to take care of our patients or take care of the staff that take care of our patients. This is a serious need in healthcare. And if it were just Geisinger, that's fine. But I've come to learn, because GS1's a global business, this is a global problem. This is not something that we just struggle with here in the U.S. or in a third world country. This is a global problem.
I've seen exactly what you're talking about. Is here's your pad and pencil, here's your printed off Excel spreadsheet, and you're counting for annual inventory, which is a need for the CFO, and what's our financial, how much is on the shelf, hopefully none is expired. Is the UDI opportunity, how do we take them from current process on a lean opportunity? There's a political piece of this too. I know sensitivity, that they're like, are they willing for change? Are they willing to move it forward in the direction they need to? And the timing of it, there's a big time downstream. How do you get that buy-in? And how do you create some simple wins and simple efficiencies to get those individuals to partake in the change management, which is a word we pummel all the time? How do we move to the next steps? How do we get them there?
Yeah, fortunately, there's an old expression, right? Never waste a crisis. There was a cardiologist that said, we're going to upgrade what I call the EMR. It's not the EHR, which we use. It's the Epic EHR, right? EMR is like a sub-level. So this has been what was running the cardiac cath lab at Geisinger. And he said, we're going to make an upgrade. It has an inventory control module in it. You can use it, or you can partner it up with something else. But we're going live on June 6th of 2010. This was not June 6th. It was about 6 months prior. We called up our partner on the ERP side, Lawson, and said, hey, who do you work with in this space? They gave us 3 names, did a quick evaluation. Ended up one of the vendors was more aligned with what we needed to do because we had a previous relationship with them. And we said, all right, we're going to go live with this point of use, point of capture tool. But that was one of those crisis moments because it was very clear. The doctor was going to go ahead with or without us, right? But we took advantage of that opportunity. So to answer the second part of your question, it was kind of inferred. How do you get it to scale? How do you get it to change? As soon as we went live in the first cath lab, people were like, well, wait a minute, what about us? Because now you've got a team that has this scanner that's checking expiration date and it's giving them their inventory consumption, which is telling my purchasing people to resupply if it hit the par trigger, right? And they want in. They don't want to be typing in part numbers, right? So it took on its own kind of gravitational pull. And we had to just serve the customers. We had to serve the front line. We hit a little bit of a stall when it comes to getting it over into the OR until there was another crisis where we had to do the chain of custody on tissue. So in 2018, we took advantage of that crisis and we started into the OR. And now, finally this year, I think we're going to finish the OR. So visibility, like I said before, I could walk out of healthcare and go, okay, at least I got that one done, right? We gave them visibility. But there's so much more beyond that, right? I mean, if you do any problem analysis, Ishikawa diagram, right? Man, material, method, machine, you're just getting the material under control, right? There's a lot of things you got to do in the other 3 quadrants.
There's so much downstream opportunity once you've identified that. I love your comment.
Oh my gosh.
That gravitational pull is so right on. So right on. Like, what about me? What about us?
Yeah, we weren't pushing the rope, right? We were letting them pull us. So, and they pulled hard. It was kind of brutal to go into the ORs because they're like, hey, Kevin, you told us in 2014 we were going to be not manually keying. And it took us till 2018 to get there. But yeah, it was a big tie-in when you have to get the OR, Epic Op time tied in, but we got it.
Why don't we just take one little step back and make sure everybody knows what GS1 is, what UDI is,
Okay.
Good
how
point.
they're related, and why that is so foundational. I know we've only got about 10 minutes left, and I feel like that's a 20-minute answer, but let's do our best with that one.
Justin, do you have a hard stop by chance?
Yeah, just kidding.
Okay.
And we know this question is not for Hayes' followers because they're all executive level and get it. This is more for probably Justin and I's followers.
Yeah.
They're really just learning boots on the ground, their intro. So we appreciate it. Hayes is kind of the big deal here, I guess.
Yeah, I think we'll just make it tangible, right? If you're doing self checkout or checkout of any form in this country and you hear beep, that's powered by GS1 barcodes, right? That barcode is what is put on that product to give it its unique identity, so you can associate whatever information you need to associate with your point of use, point of capture, point of sale system. I think that brings everybody into at least saying, oh, okay, that little UPC code or whatever, that little 2D data matrix thing, right? That's powered by GS1. But GS1 says, hey, you know what? Identify, capture, and share, right, are the three tenets, right? When I scan that, I need to know what it is. I need to capture information, and I probably need to share it. Healthcare is a little bit trickier because we have to share information that's going to stay in a patient record probably for a long time, right? They'll actually reuse a barcode in retail. We had to change the laws in GS1 and said, yeah, no, we're not going to reuse barcodes, right? Once you put that item identifier on an item, it stays. And that's primarily because of the second question you asked, how does it tie into the UDI? Well, the UDI is a mandate from the federal government, right? That all devices would have a unique identifier. And along with that unique identifier, it would have production information that said when it was made, when's it going to expire, and does it have any lot or serial tracking capability? Now, that's not a foreign concept to consumers either, because we get recall notices all the time on our vehicles, right? You got to bring your vehicle in, you're part of a recall. Unfortunately, that doesn't happen as well in healthcare. And again, it's that parity, right? It's that, wait a minute, isn't my life more important than my car? But we actually have a challenge in U.S. healthcare to try to bring information to people that have been receiving medical devices, because it's not a uniquely identified standard. So you could have, prior to the UDI, you could have the same part number on two different products. That's not good, right? You could have it on a knee or you could have it on an eye implant. So UDI says can't do that anymore. You have to have a unique identifier. There are two other issuing agencies that operate in this space as well as GS1. GS1's probably, according to my QSAPE data, about 60 to 70% of the device identifiers are GS1 barcodes. HIBIC is a big player, the HIBCC, and then ICVA, which is the blood and tissue world. They're probably about 6-7%. They're all unique. They all meet the qualification of an issuing agency, and we use all of them every day in Geisinger, right? Our solution partners have to be able to work with any of the UDI standards.
Well, there's a reason we chose you to be our guest to talk about GS1, and it's because you're involved. So I thought maybe you could tell everybody, how long you've been involved, what that looks like, and then also how do we get more people pulled into this and help build the foundation kind of underneath the house? Yeah,
so I think the interesting thing about getting involved is first awareness. We met at ARM, the American Health Resource Material Management Conference, Justin. Mike Schiller and his team, great partner, right? I just asked Mike, Mike, if I send a message out through ARM, who am I hitting and who am I not hitting? Because I'm not getting enough people involved, right? I'm not getting enough people involved in UDI. I'm not getting enough people involved in the Drug Supply Chain Security Act, which is also built on GS1. So that's interesting. I'd love to have the magic answer to how to get people involved. Right now in healthcare, what gets people unfortunately involved is what we call the stick, right? We haven't found we haven't found the carrot. We know the stick. We know fines, right? We know you'll get lower reimbursements if you don't have your EHR system up. That's just a negative motivator. It's like a bare minimum, right? I think what we want is a system where people actually get involved, like retail. It amazes me when I go into a retail store and I go, oh, that's interesting, right? They just took a whole human being or a whole human out of the loop, right? I can self-checkout. I'm waiting for the day I walk into my local store and they say, Kevin, we know you always go to this aisle first. Would you mind putting this on the shelf? I wouldn't put it past retail to figure that out, right? They've already hired me to do my own order selecting, my own order picking, and my own checkout. They just haven't hired me yet to put the stuff on the shelf. So coming soon.
Pretty cool idea, actually.
Yeah, you're going to touch it, pull it off the shelf, and it's automatically going to charge your card before you walk out of the.
Yep, exactly.
Geofencing, something. Yep.
Something. Yep. Grab and go. It's already out there.
But Kevin, like you're saying, you want more people involved. Let's just say we give you 50 more people. What is that? What will you do with them? What's the end game here?
Yeah. So if it was on the drug supply chain side, I'd be saying, show me that you are ready for the go live in November of 27, right? That you're going to be able to receive a message about your drug and verify it matches the physical product. And if not, you're going to be able to communicate backstream and make sure that you get that resolved as quickly as you can. We're very concerned that go live is not going to get delayed again this year. But if you gave me 50 people on the UDI side, I would say I'd start with the same question. Do you have any visibility or you have any lack of visibility to your inventory? And if they say yes, then I'd say, let's get started, right? Because you have to start. You're not going to get it all overnight. And if I got that 50, I'd say, give me another 50, right? Tell me if you go to a conference, right? I've said this at my GS1 meetings, my ARM meetings. I'm not in the business to sell solutions like software solutions. That's up to the vendor. I'm in the business to tell you need a solution, right? You need to put technology in the hands of your clinicians so they're not a GS1 barcode. When you scan it, it's a 14-digit numeric identifier. Have you ever punched in the wrong phone number? That's only 10. That's only 10, right? So typing in 14-digit barcode, not going to work. We need to get technology in the hands of our people.
And more than a workstation on wheels with a scanner plugged into a port. It's so much opportunity for improvement on this.
Yeah, and we didn't even talk about, sexy things like they're doing in retail with RFID tags, right? You probably heard people walk through the gate and beep, 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 beep. You got to go back and, right? But there's just so many things. With that. Yeah.
You know what? That's
how he got incarcerated the first time.
Wrong.
Mr. Skinner, can you please come back here?
Hayes, and it was a joke, and he put me up to it. So Hayes is the culprit. He's the ringleader of everything.
Pretty sure. Go ahead.
It's horrible to get 5 years of the pen for a Dollar Tree.
I took one for Hayes. God bless you, Hayes. You're welcome, brother.
All right, Kevin. Great interview. Great job. Keep up the good work. Hopefully we can get, a couple of those 50 you're looking for to get on board. How can they reach out to you? How do we route somebody to you after this?
Yeah, that's a great question. There's a couple different ways. I'm on LinkedIn, so you can find me on LinkedIn. I'm horrible at returning messages, but eventually I'll go, oh, I've got a number on that thing. But we also started a healthcare transformation group, really, really long web address. But we partnered up to try to drive standards adoptions with Mercy, Mayo, Intermountain, and Kaiser back in 2011. We have a website, it's public facing. Everything we can share, we share. You can find me every year at the GS1 conference. I was asked to try to put together a healthcare track after that conversation in 2011. So we're there every year at GS1. Our healthcare track is one of the faster growing tracks. And then ARM conferences tend to be the other place where you'll find me out in the public. Sometimes I'm on the stage, but like last time we met, Justin, I got a chance to just be in the audience, right? So I got to do some networking. But, whether you're on stage or not, you got to have a message, right? I won't get it all done before I have to check out of the healthcare game, but I'm going to make sure we have it identified and have engineers, which is the last part of my title, right? The process engineers, build a couple of really strong engineers, and I think they're good models, and I think they could create additional engineers to help make this thing stronger in the future. They just need demand, right? They have the skill set. There just needs to be a demand for the improvement.
Well, I applaud you for doing what you're doing. We all need this. And thank you so much for beating this drum and trying to get more and more people, more and more industry involved. This is fantastic.
Yeah, it's proud to serve, right? Geisinger is a proud organization, and it's in my backyard, right? So that has a double meaning to me, right? They care for people in my family every day. And I said very early on, they're going to probably care for me a lot more in the future than they do right now.
You might be that patient one day, too, right?
I might be that patient.
That was Kevin Capatch, Director, Process Engineering, Enterprise Supply Chain Services at Geisinger, talking about GS1 UDI and why you should get involved. They need more people. They want to engineer healthcare. And what a great interview, Hayes.
Oh, he's got great energy, but he also has his expertise. I mean, this guy is deep. I mean, he's way over my head and clearly over Gary's. But, I mean, no doubt he was very helpful. And I hope people that are listening to this volunteer and get involved.
All right, everybody. On behalf of Hayes, Gary, and myself, thanks for listening to this episode of Power Supply.
Got you, Gary. I got you, Gary.
Thanks, buddy.
Thank you for listening to this week's episode of Power Supply. As a reminder, you can help support us by subscribing on your favorite podcast app or by downloading the smartphone app on your iPhone or Android. Simply search for Power Supply in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@powersupplymedia.net. We look forward to hearing from you.